Thank you all for joining the monthly MIDAS webinar. I'm Harry Hawkeiser, Director of the MIDAS Coordination Center, and I'm really glad to see you here today. Our speaker today is Dr. Anuj Mubai from IQVIA, who is going to talk to us about societal and healthcare value creation. And I will, with that brief introduction, hand it over to Dr. Mubai and let him take it from there.
Thank you, Professor, for your kind introduction and also giving me opportunity to talk with the MIDAS network. So greetings to everyone. Good morning, and maybe if you are joining remotely from internationally, so the greetings to all of you. So, first of all, I'm currently working in a real-world solution team where we do health economics modeling at the IQVIA. And IQVIA is a healthcare consulting firm, one of the largest in the US, actually internationally. And we work on, of course, disease dynamics that MIDAS focus has been, but also work an extra layer on top of it, the economic value of interventions, diagnostic tests, treatments, drugs, therapies, different type of healthcare technologies. I'm also associated with Center for Collaborative Studies in Mathematical Biology at Illinois State University. And also recently I've been part of a Kalam Institute of Health Technology, which is a Government of India initiative, and for designing policies related to medical technologies. So, today I thought what would be the best thing to talk about it. So I think we see, and I've been part of few MIDAS talk, and many of the talks have focused on infectious disease modeling, and my area is also infectious disease modeling. But I wanted to give a different flavor, and I think some things that I do in my current work is computing value, and the value for something, value for intervention, for example. And I think the word value is a very general word, and I think it has different meanings in different minds. But we do it on a regular basis, so we end up quantifying the meaning of the value for various things. So I'll talking about so I'll be going over my background, my experiences in different projects, whether it is training, whether it is research, whether it is teaching, mentoring that I have done in the past, and how that has generated value for me, for society, for research community. And I will be giving some example through that journey of my background. So today's outline would be roughly, I will be first discussing on the definition. What is the meaning of value? How do we create the value? How do we capture it? How the value is lost, for example. And then I'll be going into how the values were created for me in my career, how value in a different sense by generating evidence that my work has created values. And in my research, how is the modeling output, disease modeling output, is providing us different types of value, created a different types of values. And in the very end, I will also talk about I used to run a program which was summer research program and for undergraduates, and REU program, research experience for undergraduate. And so, by the way, I was a faculty at Arizona State University before joining IQVIA. So I ran a program, and that's where I coordinated values among certain ways of values in the summer research programs through mentorship and through collaboration and networking. So before I go further, I would request, Kristen, can you please share that link in the chat message? I would love to have your input on this particular question. And it's what is the first thing that comes to our mind when we hear the word value? What is one word? If you want to describe it, what is that one word that you will say, think about? If you can kindly go to the link that Kristen is sharing right now.
I'm actually, it's not allowing me to share to anybody, but Harry's able to do it. It won't let me do it.
Okay, you got to post it in the chat now. Please check for it.
Yes.
Because I will going to see the responses as the people will going to social importance. Okay. I'm seeing 2 words right now. So please do put them. You can put few words also. I mean, few times also. It doesn't have to be one response. Okay. Okay, beautiful. Maybe we'll have 1 more minute just to so that the link is in the chat message. So social priorities, economical, okay, importance. Okay. So Kristen and Harry, you also please do put what you think about money. Okay. Maybe 30 seconds more and see if there are more words that come into that. Okay, very nice. Benefit, human, okay. Self-worth, things, okay. So beautiful. And the reason I did this survey is to show the meaning of the word is very different in everyone's mind, actually. And what we see as a value of something comes out to be very different. And so, so the question then comes is how you define it, how do you quantify it? And as you and the answer to that is all these words that you are seeing here on the screen are has to be there in the definition of the value. But it depends on the perspective that we are talking about, whether it is from an individual perspective, whether you are talking from a societal. But if you are talking from the society perspective, then all these things are very important. Individual might have their own values or preferences, but the general word, society word, has many different meaning of it. So beautiful. Thank you all for the response. This is clear. We all can see it has to do with the health. It has to do with the cost or economy. It has to do the efficiency in which we do interventions. It has to do with the humans. It has to do with the animals. It has to do with the environment as a whole. And so all these affects decision making, what decisions we make. It has a value for next things that we do in the life. Okay, so what is the definition that is known in the literature, and how do we people define it? So first of all, COVID has actually caused a profound effects on both individual and society, like illness, deaths, fear, anxiety, societal response. You can quantify in health economics, that area that I'm working currently on. We talk about quantifying the value of each one of these factors in some numerical values. How do we do that? That's a different thing. What is the evidence you need? That's a different thing. But we want to do that thing if we can get the some data to back that numerical estimates. So what has pandemic did in our life is caused us to rethink the methods that we are using for measuring health, equity, risk, uncertainty in the policy decisions, for example. For most good, the interaction of supply and demand lead to the appropriate value of a particular good. So suppose we are talking about a particular good that we are interested in. Let's say we want to buy, we saw a car, old car, very old car. And for some people, it may not be worth anything, but for some other, the value will be much higher, and they will ready to give much higher value. So it depends on how an individual seeing that. So how many are basically available to you, supply, what is the demand and what is the supply for it, that decides the appropriate value of it. And so it's definitely a societal issues, because it measures the effect of particular intervention that extend beyond a person's own interest. So how is other people perceiving it also impact the measure. So for example, COVID vaccine, if you see the value of COVID vaccines, and basically if you talk to public health officials, that will be saying, oh, they'd save a lot of lives, it reduced hospitalization. But it has also a larger context of the value, for example, coming to economic normalcy, coming back to businesses are open now. So because of the vaccine, so there is a hidden cost associated with it, and that sometimes is what is important to create a value, to quantify the value. So when it comes to assessment of the value, there are few things especially in healthcare sector. Of course, the health of an individual or health of the population. How do you quantify that? That is a multidimensional, and that's also could be a very personal. Some people can bear less pain, whereas some people can bear high pain. So it could be individual based as well. Also as an equity, for example, amount of segregation of population along socioeconomic or racial lines. So to quantify that, and these all things can go in the assessment of value. And then social determinants of the environment in which we live in, we work in, we do all those things of the daily life comes into that. So important implication of knowing value is in guiding and allocating limited resources. We all have limited resources, so that helps in guiding those resources. Okay. So I wrote a SIAM news article few weeks ago, this year itself. And we talked about how we see in healthcare sector as a value. So there's first of all, what is this curve here looking? So here we are defining a product life. Product could be maybe a drug, particular drug. So this is the x-axis, the life of a drug, and on the y-axis is the cost and revenue. Cost in producing the drug, and revenue in selling the drug in the market and getting the money from there. So this blue curve, the goal of the healthcare companies is usually to shift this curve towards the left. So from dotted curve, they try to make it as a solid blue curve. So what this curve is showing is, in preclinical stage, the first bump in the starting, below the horizontal line, that's where you are the company is spending a lot of money to build the product. And that's a preclinical phase. And then comes the clinical phase where they are trying the drug in the clinical trials, for example, and giving it to the patients if it is satisfactory and it satisfies certain conditions. And then as it goes to the much larger population, the revenue starts to pick up and increases over next few years, and then kind of drop down because there are lots of competition in the market. There are other equivalent drugs that are now coming in the market. And eventually there is a profit period becomes literally, there is no profit literally at some point of time in the future, because drug starts to become more generic. And there are lots of low and middle income countries where this could be developed in a mass, and the patents are over by that time. So the last period is where sometimes you need to just sustain in the market, and it's important to have the drug in the market, even though you are losing, you are putting a lot of money, and there's not a lot of costs that are coming, and people are making the generic drugs for it. And the reason is that when it becomes generic, it is used in a large population, much larger population. And so it gives you an indirect value to it, and different types of implications comes out of it. So the goal of a pharmaceutical company is basically to shift this curve to the left as much as they can. And in shifting, they generate the value. So early approval from the FDA, for examples, and increase the profit. So make it higher and shift it to the left. And that's how the major goal is for many of these companies to do. So how do we compare? There's a formula for it, by the way, on this side, which is saying the value of drug is equal to quality of the drug. And what is the quality? What is the how much access of the drug is? How much adherence to the drug is? Many factors go in defining this variable called as Q, basically. And then also the health outcomes, you add the outcomes, individual patient. This is about the population characteristic or the drug characteristic in the first, and this is about patient's characteristics, outcomes, like their side effects, their adverse events are there or not, whether patient feel comfortable in taking that thing, whether so there are many things that one can input there, and you add it with this Q and O, and that becomes the numerator of the formula, which computes the value of a drug. And denominator is all the cost. Now, all the cost, when I say, depends on what perspective that we are talking about. For example, the perspective could be of a society as a whole. Then you would have different medical cost. You could have infrastructure cost. You could also have productivity lost due to person being sick and not able to work, for example. So those costs can go in that. But you could also have cost associated with payers, for example, insurance company, or perspective of providers such as hospitals, clinics, and their perspective. And these denominator and as well as the numerator changes according to the perspective that you are talking about. Okay, so this was about a little bit about definition. So now let's what values are created in my background through my experiences. So I want to give you a gist of my last few years of experience. I'm trained as an applied mathematician, but I got experience in working in sociology of harm reductions, like illicit drugs, alcohol drinking, substance abuse, for examples. And also work with infectious disease epidemiology quite a lot, modeling of infectious disease, particularly neglected tropical diseases like leishmaniasis, Chagas, and lymphatic filariasis. And then I also got a chance to work in a clinical trials. Although I was a modeler, but I was participating in a clinical trial in couple of places, basically. So had an opportunity to do at least to work with the global health folks and collaborate with them. Not only collaborate remotely, but actually living together, for example, a few months while being part of the clinical trials. And so really get the chance to see how they work, how do they work with the different communities, different cultures, different language groups of people. So I was in Papua New Guinea for a lymphatic filariasis trial for mass drug administration, for examples. And now I am working in a company which is a health economics company. So truly a very wide variety of experience that I have got. Now, for my understanding, I think there are two ways I see the modelers or scientists are, the specialist and the generalist. The specialist are kind of goes into very special cases of the things, problem of interest, whereas generalists look at many different features, although may not go deep into this particular aspects of the mechanism or drivers. So specialists, they are kind of little cautious. They go over only the things, special things for which the data are available, whereas generalists try to browse other areas to compute value, for which even the empirical data is unavailable, but try to pinpoint that if you ignore these aspects and that are important for dynamics of value creation, then you may have these consequences, for example. But that opens up the new door for empirical scientists to go in the field and capture some of those data that is not available earlier. So there's the benefit for both sides, but I feel I am more like a generalist, in which case I have got some experience in different areas. So, the value that is generated in me to this is I am started to understand that there is something called as participatory democracy. That means I am also simultaneously do that whatever interests me is like, for example, I want to work on a particular model, so go deep into the modeling aspect. But I also want to make sure that it is a value for suppose I'm making a model, it has a value for the for folks that I'm making this particular model, or they are interested in for decision makers of something. So it has two things. When we call it as a participatory democracy, it is an individual liking interest of a particular special case, but generalist in the sense of working with the community and working with the interdisciplinary team. And that is what I call it for myself, has generated the value in me. So I've done few studies where the value has been generated by evidence that I've collected in my work. And the evidence was not really there, or was limited there, and it ended up. So before I go into my study, I want to point out some of the companies who have turned the COVID crisis into opportunities. And they are doing a marvelous job. They have succeeded in that doing, and they have done an amazing job in doing that. And I know the challenges that comes into doing something in novel evidence generation. So, for example, this Anacity is a technology solution provider, which is actually for the gated community. It is provided to the gated community. Their product is their platform is provided to the gated communities, residential communities, and basically what they do is they collect data for different things. For example, they have cameras, they have thermometers at important junctures. They are calculating overcrowding. They are calculating temperature of an individual. They are computing many different features that are very relevant for the COVID pandemic not to spread, COVID infection not to spread. And they have been very successful in implementing these things. So this was a novel evidence generations from how do you bring out the value, because these things were already there in the market for a long time, but bringing it to the residential community so they have made this community touch free. You don't have to even touch anything, and you don't have to go into the places by default. There are ways to stop you from going places where there are potential for high risk within the residential community. So amazing platform that they have. Another thing is BioBot Analytics. It has been in news and the money. Now, they are doing, basically, they are trying to analyze the human waste. But the problem there they are probably would have faced is multiple sites and time points. And, in the human waste, they are trying to track the COVID infection. But COVID infections are, when it is in the human waste, we don't know actually how long it will be there in the human waste, and what is the dilution level. So there are lots of difficulties. And when you do it at a different sites, you need to normalize it in some sense so that you can use it as a community level infection, to quantify the community level infection. So this is a lot of work and a lot of innovation that is needed in doing something like that. And they have been quite good in some of these things. And they are tracking many things like other substances, for example, opioids. This another one is Ekincare, and they uses the medical documents. This is a platform that they have given to, and they are collecting documents, the data on a various end as well. But the one important thing is they are bringing the complex medical data. One of the problems that we face is our medical bills are very complex and very sometimes could be confusing, especially for people who are non-medical people. And so they are provide different graphs, different analytics to simplify the data. And maybe that this might be there in some companies before, but somehow they have been very successful in doing it promptly and successfully for after COVID. To understand how is the value created in our daily life on various projects that we do, one thing is to start thinking about how things can get failed in spite of a lot of resources available to us. So I want to give an example of a big tech companies that have failed in the healthcare. So healthcare industry is huge, by the way, and it continues to grow, $4 trillion market. But despite of that, in last decade, there are few companies that are failed drastically. Like Google Health division is disbanded. Apple used to have an health habit app. It has to scale it back. IBM Watson used to have AI data analytics platform 10 years ago. I mean, they're thinking about, and it is sold off. Amazon with Chase and Berkshire Hathaway, they used to have something called as Heaven Health, that is disbanded. These are all big companies, the resources available to them. And in spite of that, they failed miserably in these projects. Of course, now things are changing, but at least in these projects, they failed. And the reason they failed is they were using small patient data early on, and that's it. And they were basing their app or their platform on some selected data, basically, which is very adaptable in nature. That's what we have realized even at the COVID. I mean, they have realized it long time back, but I think realizing it as you need some major thing to happen, like COVID crisis, for example. And also, many of the companies sometimes have marketed a lot of big things about their product, but not taking care of the accountability, if any feedback coming back to them thoroughly. One thing which has been key is domain expertise. Of course, they have talked to someone who are practitioners, who are clinicians early on in their projects, but they have not continued to weave into the discussion as their app was developing. And that is what we mean by domain expertise, that you need to weave into it every day information. So you have to have clinician and practitioner in-house for a domain expertise to truly make use of it. And there is something we have now changed. What we used to think as a partnership model is just collaboration happening, interaction one time or two time is not anymore that. It has to be in-house collaborations of domains that are key to the problem and to defining the value, for example. And of course, there has been some issues related to HIPAA compliance, which is to make sure the secure and safe data sets. One thing they did not realize also is the healthcare data is very, very dirty. It's not structured properly or collected properly. And I think there is a lot of work that we are realizing now after COVID is to structure it somehow. So that the analysis is not a problem. If you don't have a structure, the most of the time is spent in the making it, cleaning the data, basically. Okay, so I want to give you an example of how is value created, and so one very good example is the heart, which is highly active antiretroviral therapy that is for HIV. In mid-19, it was developed, and it was very expensive at that time, probably like 10,000 per patient per year, something, $10,000 US dollars. So it was very, now it is like $100 per patient per year, roughly it costs if you have insurance. So it is not that expensive now, but that time it was very expensive. So life expectancy due to the heart, availability of heart, has come down drastically. In 1984, 22 years life expectancy was estimated, but now due to this heart, it is estimated in year 2000, it was estimated as 51 years. So literally it has become more like from a deadly disease to a chronic disease. A very good example is the famous basketball player Magic Johnson, who was diagnosed in, he announced actually in 1991, and he has been healthy with using heart. Of course, heart has developed over a period of time. So what you see is the survival curve on the left side. So it is showing that 22 years in 84 to 51 years in 2000. So people have done cost analysis on their health economics aspects, and apart from looking at the transmission dynamics of the HIV. And what they have found is the 5% of the value is created only went for innovators, the people who discovered heart, and most benefit with to the patients. And so therefore it has made the disease now as a chronic now, rather than as a deadly diseases. So this is a very good examples that how the value shifts. Also, it's dynamic in nature, by the way. The concept of value is now a little bit changing also. Big tech companies are now getting involved in every aspect. I think it will be unfair to call them as a tech companies. Rather, they are now called as maybe called as a medical device companies, for example. Like Google Worley is doing a lot of work. Apple portable diagnostic division is doing a lot of work in healthcare. So there's lots of investment they are putting in it. And why I'm talking about that, because they are doing it, but now doing it in a very different way. Remember that I showed the slides of that why the big tech firm fails. They are trying to take care of those 5 aspects into the new way of doing it, so that they don't fail this time. So if you see Google Worley team, they have clinicians on board, and they have public health practitioners on board, and not only the tech folks, and a collaboration with physician or healthcare sector. Another aspect is, there are lots of new diagnostic surveillance for surveillance and detection that are coming to the market. Like Galeria is a test, a blood test for cancer, and it can test 50 different types of cancer at a very early stage. That is what it hopes to. It is important to take care of, and that's very good thing that you have a test early on to detect 50 different types of cancer. But there is another aspect to it, which is a psychological aspect. That is that if you detect the cancer early on, you are bringing more anxiety to the population, and that is also creates the value, or decrease the value, basically impact the value, I would say. Anxiety will be consumed in our culture, and how do you balance that benefits coming out of the health technology versus negative connotation to attach to it? So those are things should go hand in hand in computing the value of a particular interventions. If suppose we want to talk about Galeria interventions here. There's a CAR T technology therapy also coming, which is like basically training immune cells of someone person for the treatment of the cancer. Now, social media is also being so far usually we have been seeing as information and misinformation that has been circulated, and that has been known. But what it is now being used to empower patients of informing about how to use certain things, or some kind of information that for them it may not be readily. So directing the information to the right audience and empowering patients quickly on is also they are trying to for social media. So how do you see that? So that is the value now coming as how do you empower the social media to cater those patients? One of the a lot of work we do is on rare diseases. There are chronic disease that are there, cancer, oncologies, treatments, diagnostic tests, cardiological drugs, for example. But there is rare disease is a lot of work people have been doing. There are 7,000 approximately. Only 5% have the FDA approved drug. And that is the reason why a lot of work has also been in. But since it is rare, there is a small population that are there. So there are a lot of issues with that. So basically the sample size, sometimes you will unable to get it. So how do you generate the value? How do you quantify the value if your size of the sample is very low, the implications coming out of that sample is low? And the second thing is not only the clinical efficacy that is less quantified, but also, the person who's the pharmaceutical company who's making the product for a rare disease don't have to see the benefit coming out in a long run. I have to see the revenue. You saw the revenue curve going on the top, which I was showing earlier. So it's not only the clinical, but market share, for example, in a long run is very important for some discovery to happen in this area, new interventions to come into the market in the real. So because of the small size, small number of patients, both cases suffer in some sense. So creating the value is much harder in doing something like that. So just to give you an example, there's a medicine that comes out for spinal muscular atrophy. That's one of the rare disease. Its name is Zolexma. That's a treatment. It's a one dose given to a child, and it has to be given before a certain age group, but otherwise it will not be effective. But and it could do wonders in the person's life. But it costs like $2.1 million US dollar. At least few months ago, it costed $2.1 million, which is a huge, massive amount of money. So it depends on who wants to use that one for that massive amount. And there has to be some mechanisms of creating the value or showing the value in a much more societal perspective for it to be useful in that regard and support to come out in a multiple dimension. Okay, so my apologies, I'm moving from many different topics, like from infectious disease to healthcare and to like pharmaceutical industries as well. So the modeling values creation at various scale for policy disease. There's different scales that we do modeling for knowing this. So disease dynamics, of course, then we have a layer of economics cost. And also, this is a layer of population behavior that we are realizing from disease dynamics. The population behavior is important to quantifying the transmission rate, for examples. But another aspect is once you bring the intervention to the market, what is the acceptance level, whether people want to take it or not. It's not that you show the clinical efficacy and the cost and the people are ready to take it. There has to be a population acceptance that should come into picture. And then, as I was talking in the Galleria case, the anxiety that is creating, destroying the value is also needs to be captured in the policy data. And these are the way that we have to build the model rather than just capturing a certain aspect of the disease dynamics there to implement. So if we really want to impact the policy decisions, for example. So, a few years ago, like 8 years ago, I think we worked in Chicago, and this work was on high school dropout rates. And again, we are talking about evidence generation in my research work, and I don't want to forget about the timing. So let me see if I'm not. I'm okay with the time, right? Kristen, Harry?
Yes.
No, you're
Yeah.
fine. You're fine.
So this high school, the dynamics of why students drop out, and there is this Bashir. He was my graduate student, and he was a teacher at in one of the high school in Chicago, and in South Chicago, which is he was seeing in that area there's high dropout rates, and so he wanted to be he was concerned about why is this dropout. So we use these dynamical tools to study that thing, and this was kind of highlighted in the press also. In the BBC, for example, they after our publication, they kind of highly shared this news also for that. So the idea was, how do we study the high school dropout rate? So we actually did, the first time we created, we are trained as a mathematicians, for example. I'm trained as a mathematician and I was in a math department, but it was, we carried out social surveys there with the help of social scientists. So we generated our own social survey for a high school kids, and the teachers in this high school that he was a teacher at, Bashir was a teacher. And we collected the data to parameterize these dynamical models. So we were looking at various factors, like, for example, school factors. We were also looking at parental factors. We were looking at individual factors in the models. And, one of the main part that it highlighted, parental guidance is very, very important. There is a lot of single parents, basically, how regressly parental guidance is there in a student's life, in a high school student life. And that was a key. But the peer influence was overpowering parental guidance. And I think peer influence, high peer influence was creating, shifting the balance from more on a parental guidance than peer influence turned out to be an important integrant in the high school dropout rate. So quite an SIAM article, or SIAM News also basically highlighted this, our work in this thing. Another where we collected evidence was on mass killings and school shootings. Here we took work. These data are not available easily, and so we had gone onto newspapers. We have gone into some websites where we could find news article, and we kind of collected this data to extract the value what we were looking at. So basically, we wanted to see, my background was infectious diseases. Contagion process was very important in the infection to spread. So same idea, we wanted to see if there is any incident happened of mass killing and school shooting. There's a huge hype in media. And that, all channels are showing and a big, most of the time. And so the question that we wanted to look at, if there is any contagion effect of a next occurrence of an event. And so, the value comes from not only finding out the data, collecting the data in a right way, but also come from what methods to use for it. Now, methods that I worked initially was dynamical system, partial differential, ordinary differential equations, stochastic process. But here, standard stochastic process. But here we use Hawkeye point process, which is basically a sum of exponential decay process. And basically what it's saying is, as soon as the media attention events happen, there is a media attention, and the media attentions goes down exponentially until the next media attentions comes into pictures, and so on and so forth. So from that, we wanted to extract how much is the contagion impact. So for example, on an average, what we found is temporary, there are 13 days of this probability of inciting the next event last for approximately 13 days. And at least it incites at least 0.3 new incidents. So quite interesting work in that regard. It's got into press also, like Morgan Freeman's show. We were on Morgan Freeman's show through the wormhole. They talked about this thing for a good amount of time, and they had us on the channel as well. So now I want to shift my gears from evidence. So the example that you saw from my work is from how I generated evidence for quantifying the value for different things here. But in the research also, which is where we did not calculated evidence firsthand. I mean, I worked on modeling of infectious diseases modeling, although I had some work where not directly the surveillance I was involved with, but I was involved with the mosquito surveillance, for example, in Latin America. So I want to highlight primarily last 2 decades of infectious disease modeling. I mean, infectious disease modeling goes back long back. I mean, in some sense linked with John Grant, which is called the father of demography. Basically, he used a simple structured the mortality data from the city into categorized as based on diseases. And then this, which was 1600, and the 1900 was Ronald Ross, talked about malaria transmission cycle, and he is very important in person for someone to know infectious disease modeling should know about Ronald Ross in that. And his students talked about threshold behavior, and compartmental model description starts to pop up in that. But I want to highlight last 2 decades, which is in 2000. There are 3 main things that comes to the limelight. It's very important from a modeling perspective, what I see it. Again, there are other things that has happened in last 2 decades, but these 3 things is very, very key that I see. First is a foot-mouth disease, which is 2001, 2003. Epidemic was captured before that also, but I think it was the first regular integration of empirical evidence and modeling efforts going hand in hand in taking an informed decision. Although it was the first examples, so how many animals needs to be killed was decided. That was the interventions, and modeling was heavily used along with the evidence from the field. Before that, there was less of evidence was used and more direct evidence was used. But here was the first example in the last 2 days. Now, in early 2000, there's many things happened. There was a 9/11 attack. There was anthrax attack. There was of course, influenza outbreak was going on a regular basis, and that SARS-1 was also there. So US government has established basically at that time preparedness task force, and that task force, the constituents of that task force actually helped. And what I know about is that task force consists of people from many different disciplines, and not only public health practitioner, for examples. So basically they wanted to cover many different areas because they were really worried about bioterrorist attack as well as an outbreak or pandemic or epidemic. So this was very highly interdisciplinary team, the task force, and that initiated that task force, and the funding to this task force initiated a lot of good work. And I think that is the time when 1918 Spanish flu was studied quite heavily. And there were lots of papers about 1918 Spanish flu came into till 2010, 12, 13, something like that. There's lots of work on flu, basically. So that was it was very interdisciplinary task force and led to many good work into understanding of 1918 Spanish flu. Now, flu forecasting also started to be in 2013 onwards. Now, why I mention this thing is because that is the time ensemble techniques, like many different models using to focus, begin to pick up in large scale. Although it was very spotty after flu forecasting in 2013, it kind of spotty. Not every place it was happening until the COVID came, and then this ensemble techniques becomes a big deal, and CDC is now kind of carrying out these ensemble techniques. So the modeling has grown tremendously in last 2 decades, exponentially, I would say. And evidence gathering on a regular basis and data-driven practices are becoming a key lately. So the value require capturing dynamics of a problem. I mean, then how do you capture the dynamics? Basically, dynamics is just a pattern. That's the first step for value creations. So the first step is like, what models do you use, basically? So you look at the trend. And simple, the Ross McDonald models are basically recurrent epidemics, which are damned in nature. That is what is created. But now there's other things that we are understanding from some studies for the COVID, for example. Social behavior capturing, you see the blue curve, this is social activity. If we capture the social activity in a more proper sense, then it will capture the data much better. The blue curve is capturing the data, but typical standard SIR model is kind of overestimate the burden of the disease, for example. And also another thing, the mobility patterns and diffusion of the populations are also key in capturing. So as we know, standard SIR models have damned oscillations. But if you have rebounds of it with a smaller peak and then higher peak, how do you capture the mobility, and the diffusion can generate some? These are the mechanisms that might generate these things. I'm sure there will be other, but these are some of the things that and also this work that is where the shoulders in the outbreaks, the patterns in the shoulder-like phenomena in the patterns of the disease could be generated from the fear of the population that is going on. But these are behavior aspects that could be also captured in it. So another example that I want to give is, during COVID, there was rapid molecular test was coming in the market. And one of the work that we did was to quickly wanted to understand the economic value of how better is the rapid molecular test as compared to the PCR test. So rapid molecular test is basically quick, but the problem with rapid molecular, it has a low sensitivity and specificity as compared to the PCR. PCR is very good, but was taking at that time longer time, 2-3 days, basically. So here, typically what we were, usually the dynamics is important here. We were trying to capture the dynamics of that is in the community of the infection is spread, as well in the hospital settings, the infection is spread. And, point of care testing means, this chat. Okay, so I think we are out of time. So I just want to wrap up this thing. Basically, here was we were taking different types of cost, and what we found here is that PCR, the rapid molecular test is better, provided you capture the dynamics well in the hospital settings, and also the wait time in the PCR test is less than 2 days. So very important implications from the work. I think I will skip this work and also this works. So I want to show the mentorship through the mentorship. I was involved with these 2 programs here. One is the Mathematical Theoretical Biology Institute, and we did number of things there, and it has been amazing programs, and it was initiated by Dr. Carlos Castillo Chavez in 1996. I was a director of this program also for a number of years. And one thing that we were using is a flipped hierarchy, because the research question was coming from students, and we were just guiding and shaping it into the scientific work. And therefore, the mentors were also like students, because it was not necessarily in my area that students come out with an idea. So it was, we called it as a flipped hierarchy, and that was very important thing. And this other program, National Alliance of Doctoral Study, founded by Philip Kutzko, and one of the things he's developed is a community of mentors and scholars, which are continuously creating values for other community members, the new generations of scientists. So the very important point, I want to end here with this highlight here. It has challenged, COVID has highlighted the challenge. The partnership model is very important. We should not be married with a type of model or data set. Simple, but a data-driven practical framework generates much higher value, basically. Handling of uncertainty is a central concern for the value creations. And building community for the new generation scientist is value generation for the new generation of scientists. So I'll want to end here. Thank you very much for giving me time and listening patiently. I'm open for questions.
Great, thank you for an interesting talk. I'm going to throw out one quick question here, and I don't see any others at the moment, but I guess when I think of the criticism that have over some of the public policy decisions over what gets valued or not in the course of the COVID pandemic, it really seems to suggest that the perspective that is taken on assigning value and calculating value is really important. So how do you ensure that models really bring in the right range of values and incorporate all of the people who might be impacted, who should have a say in what values are brought into policymaking?
Well, it's $1 million question that you have asked. and this has been a debate for many times. What is the sufficient number of value elements that you should consider that would ensures that you are capturing the, it's an adaptive process. That's the word I'm using in the title, is the dynamics of value creation. So it's usually what it initiates with, what are the evidence available to us? Sometimes you think that other value elements might add drastic value to it, but the evidence may not be available to it for that. And so that's why it has to be a data-driven, it has to be evidence-driven value elements. You can highlight what it will do if a certain value element is not incorporated, and to what extent the value will be underestimated, for example. But I think the important thing is key evidence available. I mean, COVID, the value we were delayed in generating value from the models were because we were quick to use the old models, and rather than seeing what evidence is available and we can use it by our extensive collaboration. Sometimes the evidence may not be available in-house, and we may have to get it from other external sources. So I have not given you an exact answer, but I alluded to some of the points.
I think it's actually more of a political and a sociological question. It is a modeling or mathematical question in the end that says, we are always making decisions about the scope of what we value or don't value, and it's either implicit or explicit, and often it is implicit. So it's very easy to have a narrower view than might otherwise be held, but I don't think evidence is the only factor there, because it's a matter of what evidence you look for because of what you value, as much as it is the evidence driving how you do things.
Absolutely. I completely agree with that. Beside evidence, there are also other factors that go. In health economics, they have designed something called as value flowers. So they are describing certain elements of the value flowers that constitutes the value from their perspective. And one of them is funding decisions. I mean, there are many sources of that. So, but the point here is that, in those value flower, there are like 16, 17 of the value elements, but only 4 or 5 of them we typically use on a regular basis.
Right. Okay, well, we're a couple minutes after the hour, so I think we should probably wrap up. We do have, let's see, one quick question perhaps. How can we incorporate costs and revenue into the mathematical models? Can you give a real quick answer to that?
Sure. I mean, actually, it is the way it models typically is that you have a transmission dynamics models, and then you have different disease stages. You find the unit cost in those disease unit cost. How do you calculate the cost? That's a different things because your cost could have many components in itself. But basically, unit cost of 1 person cost of doing certain intervention, you multiply with the total number of people in each infection stages, and that simple way of incorporating the cost structure. So it is an added layer on top of the transmission dynamics models, basically.
Okay, great. Thank you. And thank you, Dr. Mubai, for an interesting talk and a different perspective on these modeling questions. I think we're not having a MIDAS webinar in December because of the holiday season, so we will see you hopefully all back in January at the next one. Thank you all.
Thank you, Dr.
No, hey, we do have a webinar in December.
Oh, we do? Is that December 9th?
No, we have that special one December 9th, and then we will have one on December 16th.
Okay, thank you, Kristen.
Sure.
We'll be putting those announcements out in the MIDAS Weekly Update. Take care, everyone. Thank you.
Bye.